Good afternoon, everybody. First of all, I would like to thank the organizing committee for giving me the chance to present our work here today with you. I will start by doing a brief introduction showing some of the available scientific evidence of the benefits of HEART. Then I will show you some figures of the current situation of HIV/AIDS epidemic in our country and testing policy that provides the rationale for our study. As all of you know, thanks to the great progress made in HIV treatment and expansion of HEART programs, survival and quality of life of people living with HIV/AIDS has improved significantly, turning HIV from a lethal condition into a chronic and treatable disease. These benefits are not only seen at the individual level, but also from a broader public health perspective. Strong proof of concept of the preventive role of HEART have been seen in studies of vertical transmission, HIV serodiscordant couple, and also at the community level. However, and although it may seem obvious, a prerequisite to be able to see all these potential benefits of HEART is that people get tested and become aware of their HIV status. In Argentina, it is estimated that there are approximately 130,000 people living with HIV/AIDS, with an estimated population prevalence of 0.4%. However, approximately only half of them are aware of their HIV status, and nearly 1/4 are diagnosed in advanced stage of immunosuppression. The epidemic is concentrated in Buenos Aires city and surrounding, where the red dot is, and where almost half of the HIV-infected individual lives. Here, the rate of late diagnosis varies between 12 and 30% depending on the age, gender, and transmission group considered. With regards to HIV testing policy, on the one hand, and with the exception of antenatal care, HIV testing in our country is always client-initiated, with an opt-in approach that requires a separate and written informed consent for testing. On the other hand, and despite HIV testing is provided free of charge, there exist several structural and socioeconomic barriers that contribute to the high proportion of people unaware of their infection and late diagnosis, as I have just shown. Furthermore, and although Argentina presents a concentrated epidemic, the number of new HIV infections in populations not traditionally considered to be at high risk is steadily growing. Therefore, if we want to modify this trend, we need new HIV testing strategies. That's why we decided to start with a universal HIV screening program among inpatients from an urban public hospital. The general objectives of this pilot study were to evaluate the acceptability and feasibility of this program and to estimate the undiagnosed HIV prevalence in this population. As I have just said, this is a universal HIV screening program among adult inpatients from a public hospital from the city of Buenos Aires. Patients with previously known HIV infection who were unable to consent or who are readmitted during the study period are excluded. All eligible patients are actively offered HIV testing free of charge with an opt-in approach as required by current Argentinian legislation. I would like to emphasize that testing is voluntary and results remain confidential. In this slide, you can see the algorithm of procedures. Briefly, two designated attending physicians identify potential eligible subjects among newly admitted patients to the internal medicine ward. Within 48 hours of admission, they approach them and give them printed materials with information about HIV disease, modes of transmission, and the importance of testing while inviting them to participate in our study. Those who accept, and after signing the study informed consent and and completing a short socio-demographic survey, are offered HIV test. If patient agrees, this is done using the blood that has already been run for other routine analysis, so initially no other blood extractions are needed. HIV test is done following the standard protocol, so if the first ELISA is reactive, it is subsequently confirmed with another ELISA and Western blot. For those patients who prefer not to test, declining reasons are registered. both with the handing of negative and positive results. Post-test counseling is offered with a more extensive psychosocial support available for patients in whom HIV infection is confirmed and also for those who requested. Patients newly diagnosed with HIV infection are referred to the ID division after hospital discharge to start the specific follow-up care. Now I will present some of the preliminary results of the first 6 months of implementation of our program in one of the internal medicine wards. Between July and December 2011, 350 patients were identified. Out of these, 101 were excluded, including 40 patients who already knew were HIV infected, 42 patients who were unable to consent, and 19 cases that correspond to readmissions during the study period. Out of the 249 eligible and included patients, 190, 76% accepted HIV test, while 59 declined it. Among those who accepted, 3 new HIV diagnoses were made, which results in a prevalence of undiagnosed HIV infection of 1.6%. Most common reasons given by decliners were not believing they were at risk for HIV infection in 41% of cases and having never tested for HIV before in 24% of cases. In this slide, you can see some of the socio-demographic characteristics of the included patients. As you can see, it is a relatively old population with a median age of almost 60 years, a well-balanced gender distribution, and a low socioeconomic status, as reflected by that only 34% had completed high school, more than 60% lacked medical insurance, and only 42% were employed. All of included patients self-reported being heterosexual, and less than 9% use of illicit drugs. Also, and although 55% were in a stable relationship, less than 10% of them were aware of their partner's HIV status. Of note, less than 40% had ever tested for HIV before. When we compare demographic characteristics between those who accept or decline HIV test, we found that the latter group were on average 9 years older and more likely to have medical insurance. We did not find any other significant variable in the other studied variables, any other significant difference, in any of the other studied variables. With regard to the 3 people newly diagnosed with HIV infection, as you can see from their demographic characteristics, none of them belong to a traditionally high-risk group for HIV infection, and only one of them had previously tested for HIV. If you look at their CD4 cell count, you can see that all of them, at the moment of diagnosis, were eligible to start HAART, and 2 of them were in very advanced stage of immunosuppression, as reflected by their CD4 cell count of 50 and 94 cells, respectively. Also, and although all the 3 of them were referred to the ID division, one of them did not come for his first follow-up visit. If we don't consider the case that already presented with HIV-related symptoms at the time of hospital admission and who would probably have received HIV tests for diagnostic procedures, the HIV positivity rate falls to 1.1%. In conclusion, in these first 6 months of implementation of our program, and despite the opt-in approach used, we found that 76% of eligible patients agreed to be tested for HIV. This high acceptance rate suggests that a large number of inpatients are willing to be screened for HIV. However, at the same time, we found a 24% of patients who declined testing. Most common reason given by decliners were not perceiving themselves to be at risk. Also, decliners were older and more likely to have medical insurance than those who agreed to be tested. Possible explanations to this could be lack of information, fear, or even stigma associated with HIV disease, which underscore the need to implement information campaigns explaining the importance of testing at least once in a lifetime. Also, more than 60% of our population had never tested for HIV before, which highlights that this contact with a health institution could represent an important and unique opportunity for a new HIV diagnosis. Finally, and although our study participants did not have a traditionally high-risk profile, 3 new HIV diagnoses were made, with a diagnostic yield of 1.6 or 1.1% if we don't consider the case that already presented with HIV-related symptoms. This prevalence of undiagnosed HIV population is 3 to 4 times higher than estimated HIV prevalence in our country, and also higher than the 0.1% threshold at which the CDC recommends to initiate a universal HIV screening program at a health institution, and at which universal HIV screening programs are considered to be cost-effective, similar to the screening of other chronic diseases. To finish, I would like to say that as far as we know, this is the first experience of a universal HIV screening program in a health institution in Argentina. We know our numbers are small, but this is a pilot study, and our results suggest that this type of program could be not only feasible, but also efficient in our setting. We are now planning to expand our program to a larger population from other areas of the hospital with different demographic profiles, and also to other hospitals in the city. And if these preliminary results are confirmed, our study could be the basis for a change in Argentinian HIV testing policy. I would like to thank all the people who participate in the study, especially the enrolled subjects and the team members of the ID, Internal Medicine, and Laboratory Division from the Hospital Fernandez, and also Fundación Huésped. Without their help, this study would not have been possible. Thank you very much.